Good afternoon, everybody. I'd like to welcome all of those who are joining us to this afternoon's webinar on COVID-19. Before I start, I just want to acknowledge that this is a really challenging time, not just for the speech and language therapy profession as we know, but for the nation and for the world. So there is a lot we all need to learn about COVID-19, how it's going to affect the patients that we serve, but also how we continue to deliver services for patients who do not have COVID-19. And that's something that we are also looking at as a professional body. But today's webinar is going to be one of a series that we're putting together to help those of you who are joining us, and for those who are going to watch this afterwards, have a better understanding of what we're learning about COVID-19, how it affects our patients and the rehabilitation pathway. I just wanted to say a particular thank you to the presenters today, because we've literally stood this up really quickly. It's something that we've not done before remotely either, so this is a very new approach for us. So before I start, just to introduce myself. Sorry, Rachel, if we could go back to me and who I am. So I'm Kamini Gadhok. I'm Chief Executive here at the Royal College of Speech and Language Therapists. So as I said, this is the first in a series of presentations around COVID-19, and this one is going to be focusing on critical care. So our presenters today, absolutely delighted to have our presenters today, who are Sarah Wallace, who's Consultant Speech and Language Therapist and Manchester University NHS Foundation Trust, Sue McGowan, who's a Clinical Specialist SLT for the National Hospital for Neurology and Neurosurgery, and Christina Yetzi, who's Clinical Lead Speech and Language Therapist at Guy's and St Thomas's NHS Foundation Trust. Thank you so much again, the three of you, for joining us at such short notice and putting this presentation together. If we move on to housekeeping then. So before we get started, we thought it'd be helpful for those of you who've not familiar with webinars or familiar with using Zoom to engage, for Rebecca just to go through the approach that we'll be using today. So Rebecca, over to you.
Hello everyone. So as you may see on your screen, there are opportunities to send in any chat messages to myself. I'm on hand to help today with any questions you might have about the webinar. And then also we do have a question and answers button, which is at the bottom of your screen. If you hover over it, you should be able to see it. That is to capture any questions that you might have for the speakers throughout the webinar. We will be monitoring these throughout the next hour, and we'll try to answer as many as we can in the question and answers bit at the end of the webinar. This webinar will be recorded and will be put on the RCSLT website after the event. We'll also be sending around a survey. This webinar is part of a series, and your feedback is really helpful for us. So please do fill in that survey when it comes round. And as I mentioned before, I'm here on hand to help if you have any questions throughout the webinar. Handing back to Kamini now.
Thanks so much. So in terms of this webinar on critical care, these are the aims and objectives that were put together by our presenters today. We thought to start with, it was really important just to talk a little bit about the disease, what we know, the typical presentations of a patient with COVID-19 in critical care, how the COVID-19 experience might differ from the normal scope of practice, issues around intubation, post-extubation, and finally tracheostomy management and weaning. So I'm going to pass you now to our first presenter, Christina.
Hello everyone. We would like to firstly just thank Kamini and the Royal College of Speech Therapy for all the work you have been doing behind the scenes to support the profession, and also for the invitation for us all to speak today. We really appreciate it. And we would also like to extend our thanks to everyone who's watching live and then the recording. And thank you all individually for everything that you are doing right now. We're very proud as a profession and in admiration of how everyone has really risen to the challenge during these really challenging times. So this presentation is not going to be too prescriptive, but rather provide some commentary from speech therapists who are working in ICU, around the pathways and practices to reconsider in the light of this new and emerging caseload. We are definitely not experts in this area, and we are all learning as we go. And you may leave this presentation with more questions than answers, but that's okay. And we don't have time to cover everything in great detail due to the time constraints, but we will be taking questions at the end. So before we dive in, we wanted to highlight this important question that will really serve as a starting point for every sort of management decision that we are making during this time. And that is, does our input or our intervention support best SLT practice, or is it going to actually change the medical status or outcome for the patient? And also this question needs to also weigh up and consider the risks to ourselves and our colleagues and the patients versus the actual benefits that our intervention may gain. So please just keep this in the back of your mind as we go through this talk. Have the next slide, please. So what do we know so far? Well, we know that this is a novel disease, and this is a new cohort of patients with a myriad of symptoms. We know that in the early stages, we can categorize COVID into two main phenotypes. So phenotype L, which presents more like a COVID pneumonitis, and from a ventilatory perspective, these patients have low lung elastance and low lung recruitability. And then we have a phenotype H, which is more like an adult respiratory distress syndrome presentation, where they'll have high lung elastance and high lung recruitability. And the ventilatory approach differs quite significantly depending on these patients. But this is not in the scope of this talk, but if you'd like to dive deeper, I'd just like to make reference to a link below, which is a brilliant webinar by Luigi Camparotta, who is one of the ICU consultants at Guy's and St Thomas's. So please feel free to deep dive into that. So as this is a respiratory illness, understandably, we do see hypoxemia and respiratory failure first and foremost. And however, we do end up seeing patients that will have a hyperinflammatory response that will result in a multi-organ failure picture. Now, this is due to a vasoconstriction of the organs itself. And we will in the very early stages see a viral pneumonia, but then we will sort of start to progress into an acute lung injury, cardiac injury, acute kidney injury, liver injury, and muscle weakness as the disease progresses. And we also know that this disease is 3 times more likely to affect males than females, and that known risk factors are diabetes, hypertension, and obesity. Have the next slide, please. Now, some of these patients will require ECMO, which is extracorporeal membrane oxygenation, which is essentially dialysis for the lungs for patients who are really sick and are in severe respiratory failure. Now, these patients will, in essence, have a much higher rehabilitation needs, and we have increased at Guy's and St Thomas's our ECMO capacity to 20 beds. And once these patients are taken off ECMO, they are then going to be repatriated back to their local hospitals. So you, either with or without a tracheostomy, so you will be seeing these patients, and so they will have much higher rehabilitation needs. Also, this disease is quite difficult to reverse, and so we are seeing prolonged intubations because it takes a long time for these patients to recover. So we are going to see prolonged intubations, multiple intubations with failed extubations, and of course we would expect to see laryngeal edema and laryngeal injuries as a result of intubation itself. However, Sarah and her colleagues have recently published a paper, which is just referenced here, where they are actually describing laryngeal edema and laryngitis based or as a consequence of the COVID virus itself as well, which can make initial intubations quite challenging and also can result in multiple failed extubation attempts. Additionally, we are also seeing a high incidence of acute kidney injury and the need for these patients to have renal replacement therapy, and approximately 30% of patients in the ICU are going to be requiring this. Next slide, please. This is just, for anyone who's not familiar, a picture of an ECMO circuit. So it does look quite similar to what you'd see for someone who's having renal replacement therapy, but they're much bigger hose pipes, and it's to oxygenate and deoxygenate the blood. So next slide, please. And finally, we are seeing, and we do know that there is a new neurotropic component where the virus has a preference to affect the nervous systems, particularly the cardiorespiratory centers in the midbrain, so your pons and your medulla. And I would just like to note here that we don't at this point know what impact that has on swallow function, but we are seeing patients in the very early stages with significant bulbar impairment, and almost like a brainstem presentation with really, really poor secretion management in the absence of confirmed brainstem insult. But again, this is very anecdotal and preliminary. Now, as with our normal ICU cohort, delirium is a known consequence. However, we are seeing a much more pronounced and severe delirium in this cohort particularly. In addition to that, we are seeing cognitive impairments. And there also has been some case studies that have been describing isolated cranial nerve impairments, such as trigeminal neuralgia. And I myself have personally seen 2 patients with a unilateral hypoglossal weakness, again in the absence of brainstem pathology. So please don't underestimate the value of a really comprehensive cranial nerve assessment with these patients. And the next slide, please. So I guess we can really start to expect the unexpected. But finally, I just like to point out that these are complex, critically ill patients, and therefore we anticipate that they're going to have complex rehabilitation needs. However, we as speech therapists have the skill set to treat both the acute and the rehabilitative needs for these patients. So I'd now like to hand over to Sarah, who's going to talk a little bit more about the actual ICU pathway.
Thank you, Christina. Apologies for my slightly hoarse voice, but I'll do my best. So I'm going to talk you through the ICU pathway for a COVID patient, and just not going to go into detail on each intervention per se, because we don't have time to explain all of that. But I'm going to tease out for you suppose the implications of the interventions that COVID patients are having for us as speech and language therapists, and for swallowing and voice and communication problems. So just for a little bit of context, we have some early reports that suggest that approximately 16 to 20% of COVID patients actually require hospitalization. About 5 to 12% require intubation for mechanical ventilation because their respiratory status deteriorates to that point. And overall, about 6% of COVID patients go on to need prolonged ventilation. And what we're seeing is that this is going on for weeks in many cases. So if we just look at the first point around intubation and ventilation, intubation, just in case you're not familiar with this, to be clear, involves insertion of an endotracheal tube, an ETT, through the mouth and through the larynx and through the vocal cords into the trachea, so that a person can be ventilated directly into the lungs. And there's a little balloon called a cuff at the bottom end, and that sits just below the vocal cords and actually can cause a bit of pressure to the recurrent laryngeal nerve there. So that's a thing that we already understand about ETT and intubation trauma. But the point about this is that you can create a seal for lung ventilation. In order to tolerate that tube, which is quite big, it actually fits very snugly in the larynx, that you need to be sedated. So patients are having high doses of sedation for long periods of time. Some patients, when they arrive in ICU, aren't intubated immediately. They go on to a system called CPAP, which is the picture on the right. You have a very tightly fitting mask, and it delivers a constant flow of gas. It feels a bit like when you put your head out of a car window on the motorway 80 miles an hour. Not that probably you ever do that, but it's that pressure of air. It's quite hard to breathe against. And some patients cope with just some CPAP. Others may then deteriorate and actually end up intubated. And one of the things that we don't know yet with COVID patients is if there are any effects of having prolonged periods of CPAP on the upper airway. So that's something we need to pay attention to, and I think look at possibly clinically. Many COVID patients are being proned, and you can see a picture there. It simply means being turned onto the front, and the reason that they're being proned is to optimize lung recruitment. So a patient ends up being turned onto a prone position and then back to supine position, sometimes 16 hours on the front and 4 hours on the back, and it takes 8 people to turn a patient. So the problem with proning in terms of implications for us are that we have more movement, so potentially more movement of the ETT tube, which can create potentially more laryngeal trauma. We have patients with high sedation requirements for proning, so that increases your risk of delirium, cognitive impairment. Some of the sedatives that they're using are sedatives that we used to use potentially previously, called benzodiazepines, for example, midazolam. And we know that midazolam causes pharyngeal weakness and aspiration. So look out for that. The other issue with proning is you actually have decreased access to deliver mouth care if the patient is on the front. The other things that people are reporting are, as a result of proning, are facial swelling, tongue weakness because of the pressure of the tube on the back of the tongue, and dysarthria, and just more severe dysphagia and dysphonia issues. So that's proning. If we talk a bit about us at this stage, we're not generally involved with these patients, and unless we are doing other roles on ICU. So we might be on a proning team, or we might be ICU buddies, but obviously at this stage with these patients we're not directly seeing them. But ITU itself looks quite different. Normally when I work on ICU, a lot of the patients are awake. They're not all intubated, they're not all proned with their eyes taped shut. So ICU itself is a different environment at the moment with COVID. Just looking at ventilator weaning then, obviously once a patient is ventilated with an ET tube, the goal is to try to reduce the ventilator dependence, reduce pressures, reduce the PEEP, the positive end expiratory pressures, and try to wean them off by doing spontaneous breathing trials in various ways. Often keeping circuits closed because of risks of AGP. And what we're seeing is quite high rates in COVID patients of failed extubations and need for re-intubation. I heard one report of up to 60%. One of the reasons being laryngeal edema, another one being just respiratory deterioration. So re-intubation then increases your risk again of more trauma to the upper airway. Patients are sometimes presenting with stridor on extubation, which is a sign of edema issues. If they are extubated successfully, some of these patients are then going on to require further respiratory support as a sort of bridge to getting back to more normal lung function. And again, there are AGP risks around using things like high flow nasal and CPAP, so they may be given CPAP a different way. Some of the patients though who then fail extubation or just need prolonged ventilation are then tracheostomized. We're seeing patients tracheed up to 4 weeks on ventilation, so that's a really long time. Prolonged intubation is considered 48 hours, so we're seeing them up to 4 weeks and then tracheed. And again, sometimes they're tracheostomized because they've actually got an upper airway patency issue. And they're only really going to tracheostomize a patient if they think there is recovery happening from COVID. Again, a difference is that most of the tracheostomies are being done surgically by ENT, not percutaneously on the ICU, which is the normal way of doing that. And sometimes the trach is being delayed until the patient is COVID negative. But we're seeing increasingly trachees being done on COVID positive patients now, which has very high AGP risks for ENT. And I think initially people thought that we would be avoiding tracheostomy, but again, we're seeing quite large numbers of trachea patients coming through to us on our caseloads nationally, I think. And Sue's going to talk a little bit about weaning later on, but the aim obviously is to decannulate these patients, not have them permanently tracheostomized. Can I have the next slide, please? So we are going to just assume that we've managed to extubate a patient now, and then we're going to talk about tracheostomy in a second. So in the post-extubation assessment, there's a couple of things I want to just signpost you to. On the RCSLT website, we have a really, really good post-extubation dysphagia training resource developed by Gemma Jones and Rachel Jones in Cardiff, and there are other training resources available to do with critical care there. And there's also a new paper by Martin Brodsky, which is really helpful around this post-extubation dysphagia issue. So we've already highlighted that these patients often have very prolonged intubation, and we already know that there's a really high propensity for dysphagia and dysphonia in that situation, and also that it's really regularly under-identified. And that's not even taking into consideration that now on ICU we have a lot of staff who are maybe not even ICU trained nurses, they may be theatre nurses, so they're less familiar with recognising the signs of these. So that's another issue to be aware of. There's a really strong association between dysphagia, frequency and severity, and increased duration of intubation. So I think there's a myriad of reasons which are in that little list there, around myopathy, sensory loss, trauma, and high risks of silent aspiration in these patients. So I think there's a bit of debate, I think, around whether we should see all patients post-extubation or whether we should be doing screening. So given the level of risk, my personal opinion is that we should see them all. I think the other issue is that do we have time to train people to carry out a swallow screen? Which one would we use? People have mentioned the Yale swallow protocol. That's probably the best one, but I'm not sure nursing staff actually have time to do it either. So there's issues around whether or not you adopt screening locally. We haven't, but yeah, it's a debate. So post-extubation, we know laryngeal injury is a concern. You need to look for that, look for signs of hoarse voice, pain, and odynophagia. These patients are likely to have high mouth care needs because of things like the proning and the durations of intubation. But it doesn't mean you can't still use your routine dysphagia advice to manage any post-extubation dysphagia. And the other thing to say is we're seeing a lot of patients who are absolutely aphonic post-extubation. Their voice problem begins to resolve, but isn't always fully resolved by discharge from hospital. So you may need to keep an eye on these patients and follow them up once they've gone home, because they're getting them home very quickly. Can I have the next slide, please? So we're going to talk about tracheostomy now, and I just want to make sure that everybody is familiar with the fact that when a patient is ventilated with a tracheostomy, the cuff, the balloon, will prevent any airflow up through the larynx and vocal cords, all of the areas in and out of the tube, and therefore patients have no voice. Next slide, please. So in terms of a patient who is tracheostomized on the ventilator, there again has been a lot of discussion about how we manage these patients. Everything that we normally do is an AGP. And everything that we've been trying to achieve with these patients in the recent years around laryngeal weaning, early cuff deflation, promoting passing-your valves, above cuff vocalization, all of those interventions that we have been pushing and achieving, we've almost turned a little bit on its head with COVID because of the risks of aerosol generation. So it means you need to think a bit outside the box and not potentially advocate these routine practices while the patient is ventilated. However, that is going to depend on where you work. The big risk, though, I think we all agree, certainly we as presenters all agree, is around above cuff vocalization. The reasons, from my point of view, are that very often with ACV, you will promote secretion expulsion, and those secretions may be infectious. You're also going to promote a cough, probably. We know that risks of laryngeal injury and edema seem to be high in this group, and we'd be quite worried about airway patency, and we don't have the ability to scope and look at the airway. So the danger is subcutaneous emphysema, where you get neck or facial swelling, and that's really a high risk. So we would say that although you may wish to turn to ACV because these patients have their cuffs inflated for longer, possibly, it is a risky thing to do. Other things, though, around cuff deflation, one-way valve, you just need to consider with your MDT what the right thing to do is case by case, weighing AGP versus practical aspects. You know, what's more important for your patient at that moment in time. It may be that your patient's palliative and you need to give them a voice, so you will take a risk to do that. It might be that we as speech therapists are getting involved a little bit later than we have been trying to do previously, perhaps when a patient is weaned off the ventilator. But I think we have a big role to play early on around communication and AAC support. You need to equip yourself with a batch of resources with visual aids because patients can't see your face. They are going to need a lot of very low tech, not demanding in terms of cognitive type of communication charts, perhaps, because they fatigue very quickly and they wake up and they're quite delirious. So think about the type of AAC support you can give. And I think there's still a need to carry out dysphagia therapy. Don't forget to do that. And cuff status, to me, is irrelevant. You can still carry out dysphagia exercises with patients. So I'm going to hand over to Sue now, who's going to talk about the patients when they are off the vent.
Thank you, Sarah. Can we have the next slide, please? So this is where tracheostomy patients, as Sarah has said, are off the ventilation. They may still have adjunct oxygen therapy being given to them in some form, but they're not being actively ventilated. So this is where they're doing the breathing work themselves. Now, there's a lot of fear with cuff deflation, and I don't mean that by just from us, for our fear as speech therapists often, but with patients, because of the kind of narrative around COVID, when patients are now awake and are aware that they've got COVID, obviously this is the first time potentially that they can voice their concerns. So bear in mind that there might be additional fear than what you normally see with first cuff deflation practices. But this is also a good time to be very positive about the voice that you're possibly restoring to your patient by saying, you know, well, let's use this time to do a video link, a video call with your family. And it may well be the first time the family has spoken to their loved one for a couple of weeks. So it's a potentially really important time for us to do some of that intervention. What we're being advised is that all patients with a trachea are to treat them as COVID positive because of the risks of aerosol generating procedures in any cuff deflation task. So we are advising that you wear full PPE for this, which is governed hopefully by your individual trusts, but a FFP3 mask, a visor, a hair bonnet and gown, and I think that's it. Yeah. So, but we've been really clear that if staff haven't got the full PPE available, they can't intervene. Just worth saying that if you have a patient with a deflated cuff with a one-way valve and they're self-ventilating, as they present, they're no different really in terms of how they converse than with a COVID positive non-trachea patient. So the PPE implications of that is to ask the patient to wear a mask on their trachea and on their mouth, over their mouth. And two very important bodies have advocated closed circuit suctioning. So that's the Global Tracheostomy Collaborative and the National Tracheostomy Safety Project, NTSP. And so they have said that we really need to be treating these non-ITU, potentially ward patients with giving them closed circuit suctioning. Now, I'm very aware that that might be contentious in some trusts and that there may be issues with supply. But in a minute, I'll show you what that looks like on the next slide. But before we do that, just remember that the evidence that we've all used for a long time that trachea tubes per se do not actually cause dysphagia. So consider the deconditioning, which may be a factor in those patients who've not been using their upper airway for speech or breathing for a few weeks. Okay, so let's have a look at the next slide. Can we have, thank you. So here's a picture of a patient with on a ward and the trachea layout. So the long tube coming from the patient's trachea is the closed circuit suction tubing. There we go, it's being pointed out to you now. And then the valve on the left-hand side, your left, as you look, is an HME and viral filter, which sticks on the end. That's the end of the closed circuit suction that normally goes into a ventilator. But you can see there that valve provides a kind of as closed a circuit as we can do to minimize the risk of AGPs when you're being suctioned. And then from the end of that viral filter, that's it, going away from the patient is a potential port if the patient needs extra oxygen. So that's kind of what it looks like in closed circuit suction. That's what we're trying to advocate if possible. Could I have the next slide, please? Thank you. So trachea weaning pathways. So it's worth remembering that in these times where we're all really reconsidering our staffing ratios, our staffing rotas, that we know that the evidence that trachea weaning is best done as an MDT, a multidisciplinary team will bring about the best outcomes for our patients and the best safety for our patients. So where at all possible, as SLTs, keep trying to have a really strong presence in this so that you can contribute, and I'll talk about what that contribution might be later. The question is then, do we need to do anything different now that we're weaning these patients within sensible risk discussions? What might those differences be? And we'll go through what some of those might be in coming up. One of the things that we were asked to think about is whether there would be a need to limit the tube changes. So I know we tube changes as per manufacturer's guidance, there may well be a need to have individual team discussions with your anaesthetists or intensivists or ENT colleagues about whether tube changes do need that routine change every month, or whether you can limit them somehow to avoid the risk of AGPs. Some of my colleagues are saying that they're actually they are putting in, as a first point of insertion, larger tracheostomy tubes. Again, these then might need downsizing, so we need to think about that as we go through our protocols. Could I have the next slide, please? So consider the timing of the initial cuff deflation with the MDT. So this is, remember, this is most probably off the ventilator now, because this is a spontaneously ventilating trachea patient. So we can't really emphasize this enough, and it seems like a get out clause, but we really do mean this, that we need to have case by case discussions with our multidisciplinary team colleagues. And I think the aim would be always to balance the following. Now, the reason for the exclamation mark is that there's at least 4 things that we're trying to juggle here, but let me see if I can go through them. Initially, then there's the risk of generating, of aerosol generating procedures with any weaning that we do. So there's that one risk that we're balancing, versus what SLTs can add through our expertise on the early identification and the treatment of airway or laryngeal issues that are so often underreported, versus the next ball in the air that we juggle is the contribution that SLTs we make to ensure safe decisions can be made about airway patency and bulbar function. So helping that kind of risk assessment, advising on adjuncts to support safe swallowing of secretions, for instance. And then the final ball that's in the air that we're juggling with is the rehab readiness of the patient and the patient's own needs and their goals and what their communication needs are particularly. We have the next slide. So what the 3 of us thought we should do is to put together some things for you to discuss rather than a prescriptive protocol. So again, because different institutions will vary as to how they conduct tracheostomy weaning. So keep considering tracheostomy weaning as per your usual institutional's cuff deflation weaning pathway, but there may be some nuances that you really have to consider. So some hospitals are choosing to cohort their tracheostomy patients together. In other words, cohorting all the trachea patients on one ward, and then within one bay, those patients who are being weaned. Now that might be useful if you can have some kind of input into those discussions, because that might help the reduction of the transmission of infection. But that's kind of only possibly possible within some institutions rather than another. But certainly cohorting with a view to risk managing the aerosols as you wean might be something useful that you can contribute in discussions. Secondly, consider what your agreement of the amount of time is for the patient to have tolerated cuff deflation before you might consider decannulation. So again, case by case basis, and that may well be different for the different cohorts of patients. Now, Christine's already mentioned there are 2 basic cohorts, but there are other cohorts as well. It might be the proned cohort needs some slightly longer time potentially if they're showing more airway issues for them to show that they can tolerate cuff deflation. We don't know that yet, but just have that head on you as you get to, with your team, set the time that you want that patient to have cuff deflation tolerated for. Again, think about how are they maintaining their oxygen saturation levels with their cuff down, with or without a one-way valve, depending on your institutional preference there. And then their chest status. What's their secretion load like? Is it decreasing? Are there no active signs of chest infection? Is their respiratory rate stable? It probably won't be normal, but is it stable? And what is the effect of any shortness of breath on swallowing of their own secretions? And of course, these are discussions that you're having with your physiotherapy colleagues as well. Then thinking about your secretion management, what is the patient's cough strength? Now, in this cohort of patients at this time, we're probably not going to be measuring this objectively, but we're talking about the subjective assessment of cough strength rather than with the peak cough flow assessment subjectively, in that do they have enough of a cough strength to be able to manage their secretions without relying, the last point there, on tracheal suctioning. And again, Chris will talk about different cohorts and whether that's potentially more of an issue for some cohorts more than others. What's their expectoration like? Is it effective? Is it consistently effective throughout the day? Does it depend on their fatigue levels? And what is their reliance on tracheal suctioning? Some institutions have put a number on that, maximum of 1 per shift of need for tracheal suctioning to effect removal of deep secretions. You may want to think about whether you need to quantify that or not. And then in terms of voice and airway patency, this is really where we come into our fore. Do we think that there is enough of control of voice and enough of a patent airway with either a glove finger or valve, depending on your institution's practice, to be confident that the patient will be safe should you think about decannulation? And then finally, we're not asking people to swallow food and drink before we decannulate them, or that to be a standard that we want them to meet, but how well are they swallowing their own secretions? And as I said earlier, do we need as a profession to advocate some adjuncts there? So I'm now going to hand over to Christina.
Thank you, Sue. And so again, this is just based on our experience so far. We're all in the very early stages of this trachea group, because a few weeks ago we weren't really anticipating these patients to be requiring tracheostomies, and now we're in the world of them all suddenly having tracheostomy. So here we are, and based on this preliminary experience so far, what we are seeing is that there's almost 2 weaning cohorts. So there's this respiratory failure, almost like the single organ failure group, that may or may not have laryngeal patency issues, and they actually are presenting as a kind of standard wean. They may have some ICU acquired weakness, etc., but they are sort of following, once they're liberated from the ventilator, they are moving quite quickly towards decannulation, and this decannulation is happening quite easily on the ICU. Then moving on to the next slide. There is definitely going to be a more complex group, as we know with weaning, and these are potentially going to be your patients who have been in the ICU for much longer, have had this real hyperinflammatory multi-organ failure complex, and these are going to be potentially a little bit more challenging in terms of their wean. So we are expecting these to be a hybrid of like respiratory and airway, laryngeal issues, the neuromuscular elements and ICU weakness, plus the implications of renal and cardiac impairments as well. And these patients are really going to require collaboration from all disciplines and specialities, a real multidisciplinary approach, and they will be requiring a lot of rehabilitation and therapy. And we also need to be thinking about where these patients, if we're not able to potentially wean and decannulate them on the ICU, whether the step-down wards are going to be equipped with the level of expertise to be able to manage these patients, particularly because a lot of them will have ongoing renal impairments as well, and whether the step-down wards have the facilities to cater for this. Back to the, something else just popped into my head, but with these sort of standard weaning patients, of course, they may have undiagnosed laryngeal issues because we don't have the luxury at the moment of scoping them. But a lot of them, and particularly in our institution, we are using dexamethasone and steroids, PPIs, kind of almost prophylactically. So hopefully at the point of tracheostomy, a lot of those acute airway issues will hopefully have resolved. Now, of course, we know that there will be more chronic issues going forward, but hopefully a lot of that real sort of edema will, at the point of when we're involved, may have hopefully resolved. Next slide, please. And then, of course, beyond the ICU, we don't really know all the answers, but definitely with our COVID survivors, these are some considerations. Definitely ones that we've seen sort of even on the wards are still presenting with really marked breathlessness. And so we need to be thinking about the impact of the breathlessness on the swallow and swallow breath coordination. And we don't know at this point what the long-term issues are going to be on long-term lung function. Will they end up with fibrosis or, you know, an interstitial sort of lung disease picture? We don't know at this point, and the implications of that. And of course, we need to pay attention to post-intensive care syndrome, or PICS. A lot of these patients are very traumatized and will need ongoing psychological support sort of beyond the ICU. As Sarah mentioned, these patients, majority of them are being discharged home with their not having had a diagnosis of their laryngeal or voice issues, and are therefore going home with a dysphonia or an aphonia. And so we need quite strong links with our voice colleagues in the community and outpatient clinics to be able to follow up these patients. And of course, we are going to have chronic airway issues as well, such as stenosis down the track. And so I just wanted to flag at this point that we may need to start thinking about increased, if you're not already involved, increased speech therapy input in our ICU follow-up clinics to start to pick up and tease out some of these issues. And I think finally I'm going to hand it over to Sarah, who will discuss some additional considerations to note.
Thank you. Just on that last point as well, Christina, we will be talking in a future webinar about ongoing chronic things like airway issues like stenosis. So that is going to be covered in a future webinar. So I just had a few additional points to raise, which are, I think, at the forefront of quite a few people's minds. And one of these is around fees. So obviously we've ceased all endoscopy at the moment, and I guess the first thing is to reassure members that we're working really closely and have been in regular discussion with ENT UK and BLA around the quandary that this poses, particularly with this group of patients in mind, where we are concerned that we don't want to, I suppose, slow down patient flow, where we have concerns about the larynx, the airway patency. We don't want patients to remain tracheostomized for any longer than they actually need to be, but obviously it's quite difficult to assess them without fees or nasal endoscopy. So that's something we are addressing. We've had council meeting last night with BLA where this was raised again, and we are having actually a call again after the webinar today to look at how we might address that. In the interim though, obviously the go-to person for discussions around issues and concerns you have about supraglottic airflow are your ENT colleagues. As Chris said, quite a few patients have already had dexamethasone, but it may be something that you want to discuss again, further use of steroids if you think there's an issue. PPIs, we don't know whether these patients have a propensity to have reflux issues. It seems quite common in our critical care caseload usually. So that's something else to bear in mind, whether or not adjunctive use of PPI may help reduce any residual inflammation in the larynx. It's case by case, as we keep saying. Whether you have access to videofluoroscopy or not will be locally dependent, obviously. It may be that if you do, you're only allowed to send patients who are COVID negative. But again, discussions with your infection prevention team and your radiography colleagues around whether you can access videofluoroscopy as an alternative instrumental assessment for swallowing. And the other thing there's been a bit of a buzz about is laryngeal ultrasound, which basically came about when we were considering whether or not we had a less invasive option for looking at airway patency. It's definitely been used before to look at vocal cord mobility, and in paediatrics as well. But at the moment where we're at is we have a small expert group that is looking at developing a protocol for us to potentially use in these patients. Again, everything's happening incredibly fast. And then we're going to potentially try this in conjunction with physiotherapy colleagues who are trained in lung ultrasound. And we've had a little play with it, but it's all in development. But again, if we do come up with anything, it will be shared via RCSLT. The other thing to raise is, again, we're not sure how many patients are going to have ongoing cognitive communication disorders. At the point of discharge from hospital at the moment, what we're seeing is patients who are just incredibly relieved to be going home, and they're not voicing concerns about that. But we do know from patients discharged from intensive care that 3-6 months down the line, when they're trying to return to work or get back to normal life, that cognition can be a big barrier, and cognitive communication disorders is something we need to address later down the line. And as we just mentioned earlier, because of all of the rapid increase in ICU beds, we've got a lot of new staff working on ICUs who may not understand as well the role that we have with these patients. So you've got to try to be as proactive as you can to seek out referrals. And just a flag here as well is about collecting data, because we really need to understand what's happening with these patients and what the clinical outcomes are. And we have an RCSLT data collection project, which we are hoping people will tap into and utilise, and we're going to put a link to that on this slide. So I'm going to hand over to Sue for the very last point.
Thanks, Sarah. So this is just a 2-minute, very quickly, but a huge topic, very, very important, which is just about the psychological burden, which Kamini mentioned at the very beginning, in terms of the effect that this virus is having on us professionally, let alone personally. So we know that using PPEs is very hard work, and please drink loads before you kit up. And it's very difficult to deliver assessment and therapy, isn't it? If you're kind of covered over with your face. So if you do have them in trust, there is some hoods that you can use and that physios use, and if you can use those, and also laminated sheets that maybe give a photograph of what you're trying to get the patients to do sometimes can help. Certainly don't forget to go into the unit. Remember what you need when you go and see your patients, because if you forget, it takes a long time to unkit and go and get something. So having a checklist yourself, have I got everything before I go in? But it is physically slow and it's harder work. We're also working with higher volumes of sick patients. So it might be worth, if you have the resources, to think about rotating your staff in and out of these areas. I'm sure you've all thought of that already. We know that the patients are very scared because of the narrative of COVID out there, and we know that they haven't had any family support, plus the cognitive communication difficulties, or just the cognitive difficulties they're experiencing. It might be useful to lower your expectation of what you can deliver in a day. You may see fewer patients than normal because of the time that it takes to kit up and don and doff. And then finally, just it's very important to talk with others and share how you're feeling. And I know that, Kamini, you're going to talk a little bit about Royal College and how it can help members with that. So let me hand over to you to do the final slide.
Okay, thank you. Can I just firstly say, wow, I think you're all absolutely amazing. This is such a new area for everybody in terms of the clinical presentation, and I think, as Christina said at the beginning, I think we should be very proud of the profession at this time. You've all been stepping up and doing things that you've never done before, so congratulations and thank you in terms of leadership and your expertise and bringing all that expertise to help inform thinking around assessment and rehabilitation and therapy. So many thanks from me, and just wanted to move on then to have a think about what we're doing. So the RCSLT is also trying to work at speed. We're being as reactive as we can, but also trying to move into a more proactive approach to supporting all of you, our members. And as you know, we've started a whole COVID-19 site on the website. We're also working with Rachel, who's listening in at the moment and helping us with this webinar, to build a online platform where COVID-19 information resources are going to be shared. So that's something we're going to be piloting very soon. As part of the work we're doing in collecting resources, there's a page on the website on resilience and self-care. And we are also working with members to see how many members have expertise in providing counselling support by phone. So these are all the things we want to put in place for all of you. And we're very aware there's lots of surveys going out, but there is one on the website at the moment. And there's another one that will go out fairly shortly about looking at what more we can do to support you in terms of your well-being. So just to say, you know, we are here to listen and respond. But obviously we'll be working with all of you to come up with some of the solutions that you're looking for. In terms of questions, we have had quite a lot of questions come in. I noticed there are some through the chat function as well as through the Q&A. We haven't got that much time left, but what we will do is, for those questions we can't answer now, we will obviously respond to in writing after this event. One of them was around aerosol generating procedures and dysphagia assessment. You should all be pleased to know that we have colleagues who are listening in. I think Lee Bolton, I saw that your name appeared, Sarah Wallace and Claire Mills, and with support from Marion Brady, have put together a paper looking at the evidence around dysphagia assessments being an AGP, and that's just gone live on our website this morning. That's just to make the business case. So just to let you know that we've written to the Secretary of State for Health and others on that issue and got lots of letters of support. So thank you to colleagues for that. There are some specific questions that have come in. One of them is around the use of and I might get this wrong, dexamethasone prophylactically prior to extubation. Are your ICUs using this, and has this reduced laryngeal edema? So I'm not sure who feels like they want to answer that. Sue, do you want to have a go at that, or Sarah?
Thanks. So I don't think it's being used prophylactically in my ITU. I think it's being used very judiciously because of some of the long-term effects of it. And it is being considered as symptoms arise. Sarah, do you want to say anything more, or Chris?
I think, yes. So if there are, I think it's always been used judiciously, hasn't it? And I think that there are lots of risks attached to using steroids in patients who already have a lot of weakness, potential ICU-acquired weakness issues and cardiac issues and the rest of it. So not prophylactically, I don't think, where I work. I might need to check that.
There's discussions at Guy's and St Thomas's, and I haven't heard the outcome of that meeting yet of actually doing that. So once I hear the outcome, I can update, just because of the issues that we are experiencing with these patients.
What I have also heard is of it being used for a little bit longer than it would be a normal dose. So again, the dose has been extended sometimes in some of our patients.
So another question is about advice around using intraventilator speaking valves. I don't know who feels like they'd like to answer that one.
What's the actual question?
It was, I shall have to try and find it. There's about 30 questions. Hang on a minute. Is there any advice around using intraventilator speaking valves?
I think it comes into one of Sarah's slides that you made, in terms of, obviously routinely we would be advocating the use of speaking valves in line, the Passymere speaking valve in line. But what we're saying here is, please consider the risks of aerosol generating that this procedure does. So it's not something that we would say that there's a blanket no to doing, and it may well be that for a prolonged patient who is ventilated for a prolonged period of times does require some means of verbal communication. And if they're COVID positive, that will need to be considered very carefully. We know the benefits of using those valves in line. That's not being questioned. What's being questioned is just the risk of AGPs that this poses.
Chris? Yeah, I was going to jump in as well. Not just AGPs, like in where we're working at the moment, we've had to increase our ICU capacity significantly, and there's a lot of surge nurses that have been upskilled very quickly that may not be familiar. So there's a lot of safety risks associated as well that need to be considered depending on where you work. I mean, if you're working in a smaller ICU where it's all your standard ICU nurses who are used to using that, and you have a standard of practice in place, then by all means, you've got to weigh up the risks, benefits, depending on where you actually work as well, and the staff available. Also, we now have, I think, 4 or 5 different ventilators in circulation, which we're not familiar with as well. And so you really have to make that decision based on where you work and the MDT around you as well.
I agree, and I think the other point on that is we've been talking about airway patency issues, and edema and all of the laryngeal injury issues that you need to bear in mind about whether a valve is safe.
Okay.
Particularly in the absence of being able to scope the patients as well.
Yeah, thank you. We've got another question, so excuse me if I get this not quite right. So if the patient is not palliative, would it be best to wait until they are on CPAP or even trache mask, so not BPAP, before considering cuff down and OWV trials? Shall I say that again? So if they're not palliative, would it be best to wait until they are on CPAP or even trache mask, so not BPAP, before considering cuff down and OWV trials?
I think, again, that's kind of similar to the question that we've just had. It will really depend and be case by case. We're not saying don't do cuff down when patients are on the ventilator, but you do have to consider what we've just discussed. And so it may be, and definitely practice where we are at the moment at Guy's and St Thomas's, we are actually waiting until the patients have been fully liberated from the ventilator and are self-ventilating before we're getting the cuff down. But I know our colleagues, Erin Ganelli and colleagues at the Royal Free, are doing it on the ventilator. So again, it really depends on where you work, and you have to really factor in everything.
Okay, thank you. Sorry, carry on.
Can I just add something to that as well? One of the elephants in the room here is, which we haven't really mentioned outright, is about COVID negative status, and whether you should wait to perform any of these AGPs until your patient is COVID negative, and do you trust a COVID negative test? If it's, do you have 1, do you have 2 tracheal swab negatives before you do things? And even then, these patients in critical care shed the virus for very prolonged periods of time. They've had much more severe disease. So we've actually had some patients who have tested negative and then subsequently tested positive again. So you do need to be really careful. I can't emphasize enough, risks around AGPs. You need to adapt your practice, basically, I think.
Okay, and that's one of the questions that came in about, well, somebody said about compromising usual care, particularly in light of preserving PPE. I mean, some of you have experience of trying to do things differently. Are any of you wanting to talk about that?
I'm not sure what it means by compromising PPE.
Shall I read the question?
Yes,
so
please.
How do you balance providing best practice whilst being aware of preserving PPE? Are you finding that you need to compromise the usual care you would provide?
I think that's a really good question. I think the word compromise is coming in not just because of PPE, but because of a whole host of factors. But certainly PPE definitely constrains you if it's not available, absolutely. But I would say that if it is available, it's kind of carry on and do what you would normally do if you've had a sensible discussion with your team and you think that that's the best way of moving that patient forward through their flow through the hospital. And if it's going to involve in potentially facilitating tracheostomy weans, then it's worth a few extra days of wearing full PPE going in to do that, rather than holding back on PPE and extending the patient's stay in hospital. That's a very basic answer, but it's a good question.
I think as well, absolutely agree with you, Sue, but I think it's not about compromise to me. It's about using your critical thinking in a unique situation, bringing all of your experience to bear, and adapting your practice. It's not compromising standards. You need to be as safe as you can be and still push your patients on to recover, to get them out of hospital as quickly as possible, to get them eating and drinking and talking as fast as possible. That's not in question. It's about risk assessing and working with your colleagues, which you might need to work a bit harder at because your usual MDT may not be there. So, yeah.
Okay, so there's quite a lot of questions that we're not going to get to. I think we could maybe have a look at a couple of others. We've got, and you may have covered these, so apologies, it might be my lack of knowledge. So somebody's asked, what swallow exercises would you recommend to complete with this patient population in the absence of instrumental assessment, particularly interested for trachea patients with cuff inflated?
Great question. We can go back to the literature. We know enough now about the underlying breakdown of dysphagia or swallow impairments in our ICU population. And so I would be advocating, we know they have base of tongue weakness, so your Masako exercise. We know that they have reduced airway closure issues. So with a tracheostomy, you're not going to be able to do the full Shakir, but you could definitely do a modified version of Shakir. Just be cautious of the tracheostomy, so some hand pressure potentially underneath, so jaw open against the resistance. Effortful swallow as well. Does anyone else want to jump in? But definitely your reduced airway closure, so you're looking at your Shakir and your base of tongue traction exercises would be what I would recommend for these patients.
That was on my list. Same ones.
Okay.
Cuff status is not you just don't need to be concerned about that unless your patient is telling you there's discomfort when they're doing it.
Okay. So there's a question around fees and the moratorium, but I think, Sarah, as you pointed out, we've actually got a call this afternoon about discussions with ENT UK. So we'll obviously be keeping colleagues up to date with those discussions. I'm not sure if there's anything specific. Have any of you seen a question that you'd like to answer?
Sorry, I haven't been looking at the questions.
You haven't been looking. I will have another look and just see. As I said, there are a lot of them. So there's one which is about what would you suggest for voice advice and voice speech therapy role in ICU? And I'm not sure, given what you said about the status of the patients, what do you think about that? Obviously, these are for non-sedated patients.
I would ask my voice colleague. But I think one of the issues is they're so fatigued at this point, that it's difficult to do therapy. I think that will come later if they still have persistent dysphonia issues. Everything is such an effort for these patients. They're so weak post-extubation or post-trachea.
Okay. And there's one more, and then I think we'll probably be saying goodbye to everybody before we get cut off. Has anyone encountered situations of speaking valves being fitted without SLT consultation or input after tracheostomy? Have seen this in a post-ICU COVID patient and is a relatively new starter. I found this quite surprising. Apparently this is somewhat routine in this hospital. I mean, I'm not sure if any of you on the panel have come across this, or have you heard about this through your network?
So this old chestnut, well, I think it's worth saying that speech and language therapists are really the key profession who can advise on safe use of one-way valves, who can identify laryngeal and airway issues really, really carefully, and who can help to contribute to the weaning pathways by determining length of time that patients can tolerate one-way valves, and whether in fact their tolerance is safe or not, and whether there are any bulbar function dysfunction which contributes to that safety discussion. However, in some hospitals and institutions, because routinely and historically there may have been a lack of the presence of SLT on ITUs, other professions have stepped into the gap. And you know, we have to thank them for doing that. And it may well be that you're working as a new starter in an institution where there has been fewer SLTs involved, and so often other professions like physiotherapists do step into that. And it would be worth having a discussion with them in terms of how you can then contribute to that safe risk assessment in use of those one-way valves.
Thank you so much, Sue. So we have come to the end of our webinar session. There are lots and lots more questions that people have posed. And as I said, we will get back to you after this event. But I just want to say thank you so much again to our presenters today. You're absolutely fantastic, and I'm sure that all of those who've joined today will have really enjoyed hearing, and I've seen some really positive chats online about what you presented, including from people from overseas. So it's been great to see that colleagues have joined us from other countries. The next webinar is going to I think be next Friday, so we'll obviously let you all know, and it's going to be focusing on rehabilitation. So we're going to have another set of presenters helping us with that, and thanks again, and please do take care of yourselves, and I hope you manage to get a bit of a break as well. We all know you're working very, very hard, so thanks from all of us, and goodbye. Thank you.
Thank you. Thanks for having us.
Thank you.